Hey class, I'm going to try to get this recording to you by tonight. I'll try to knock this out by 8:30 tonight and get it to you. But I wanted to congratulate all of you on your comprehensive exams. It's whether you have to take it again or you passed. That's really not important. Actually, it's actually just finding out where your weaknesses are and concentrating on those weaknesses and continuing to improve. So let's give you guys a hand for that. Stop. Okay, good, thank you. And let's go ahead and get into the lecture. Okay, this is where we ended last week, right here at this slide, the end. Let's just go and see what we needed to cover. So this is what we covered first 2 weeks. We talked about the cardiovascular exam, echocardiography, stress testing, cardiac catheterization, chest pain, edema, pitting edema. And we talked about palpitations last week, syncope, orthostatic hypotension, hypertension emergencies, atherosclerosis, coronary artery disease, angina, and heart failure. I also, under resources, I actually sent you guys a vocabulary for these hearts. I will send you another one for week 3, and I'll also show you guys some videos on the ECG that get you up and running. There's basically like 5 rules, that they go by to determine, the Q wave, R wave, S wave, and to identify all these waves and what they're doing. And this is a good baseline for you to identify what is a PQRST, what do those waves look like, and then from there you'll be able to ascertain or identify any problems with the heart. So it's not like we're going to dive deep into it, that's a whole 2-week course. Actually, it's like 1.5 years if you're going through your paramedic training, but just bear with me here. It's part of the syllabus, just so you can understand what these waves look like. And let's go ahead and let's get started.
We're really happy to have you in our course. We created this belt system for you for 2 reasons. One is we really like martial arts, and the other one is it's easy to understand. Most people know that the yellow belt is the first belt that you can acquire in most martial arts like karate or judo. The owner of the yellow belt knows the basic principles of the sport, the names of the moves, and so forth. Similarly, once you finish the yellow belt section in this course, you'll know the basic principles of the ECG, you'll be able to diagnose very important and potentially dangerous diseases, and you'll understand your colleagues and reports that talk about an actual ECG. And that enables you to further improve your ECG skills on the job. It's very hard to learn from someone if you don't speak their language, right? So in this yellow belt section, we'll teach you the ECG language so you'll be fluent real quick. But let's not waste any time and dive right into the heart of the matter. May I introduce to you the ECG curve. It consists of several distinct waves. Let's look at these waves in more detail.
Let me give you a short intro into the components of the ECG. Let's start off with the QRS complex. The QRS complex represents ventricular depolarization. These QRS complexes are easy to recognize. They're very sharp and pointy spikes. After each ventricular depolarization, there must also be a period of repolarization, and that repolarization is called T wave. The T wave can be positive or negative. Depolarization of the atria, on the other hand, is characterized by a relatively steep wave, called the P wave. Its steepness is somewhere between that of the QRS complex and the T wave. So this is the QRS complex, and it's the steepest part of the ECG. This is the T wave, and it's the least steep part, and the P wave is somewhere in between. We usually can't see atrial repolarization, mainly because it's usually hidden within the QRS complex.
Let's have a closer look at the QRS complex, which, as you know, corresponds to ventricular depolarization.
Each component of the QRS complex has its name. Naming of these components follows a standard nomenclature. There are only 5 basic concepts that you have to understand when it comes to naming these components.
Concept number 1, the first downward deflection is called a Q wave. Concept number 2, any upward deflection is called an R wave. Concept number 3, any downward deflection that comes after an R wave is called S wave. Concept number 4, a second upward deflection is called R prime. And what about this wave here? Is this a Q? Is this an S? Well, to tell you the truth, people came up with a compromise here. They said that whenever there's one large downward deflection, then that's called a QS pattern. So concept number 5 says, if the entire QRS complex consists of one large downward deflection, then this is called a QS wave.
That's it. Now let's look at a couple of examples.
Example number 1. Here we have a rather classical case. According to concept number 1, the first downward deflection is called a Q wave. According to concept number 2, any upward deflection is called an R wave. And concept number 3 says, any downward deflection that comes after an R wave is called S wave. So we have a QRS pattern here. Now let's check out example number 2. As you can see, we have no initial downward deflection in this case. So according to concept number 2, any upward deflection is called an R wave, so no Q wave here. And according to concept number 3, any downward deflection that comes after an R wave is called an S wave. So we have an RS pattern here. Now let's turn to example number 3. What I'd like you to do here is pause the video and try it out for yourself. Then come back and see how you did.
You can go ahead and pause it.
Okay, so now let's see how you did.
You're back already.
According to concept number 2, any upward deflection is called an R wave. According to concept number 3, any downward deflection that comes after an R wave is called S wave. And according to concept number 4, a second upward deflection is called R prime. So we have an RSR pattern or RSR prime pattern here. Did you get it right? Okay, so let's try another one. Again, pause the video and try for yourself. Then come back and see how you perform. Okay, so let's see the solution. According to concept number 1, the first downward deflection is called a Q wave. According to concept number 2, any upward deflection is called an R wave. So we have a QR pattern here. Are you ready for some more examples? Well, here we go. Example number 5. Again, pause the video and try for yourself. That was simple, wasn't it? There's only one concept that you have to use here, and that's concept number 2. Any upward deflection is called an R wave. But let me tell you one thing. This type of R wave is actually quite rare. Usually we would see a Q wave here or an S wave here, so you will only rarely see this type of R pattern. And one final example, example number 6. Pause the video and try for yourself. Also quite easy. Only one concept fits here, and that's concept number 5. If the entire QRS complex consists of one large downward deflection, then this is called a QS pattern.
Here are the different examples again. Take a close look at them.
Good idea to get a screenshot
Example
of
number
this
1,
when you get a
we
chance.
had Q wave, an R wave, an S wave. Example number 2, an R wave and an S wave. Example number 3, R, S, R prime. Example number 4, a Q wave and an R wave. In example number 5, just one big upward deflection, that has to be an R wave. And in example number 6, just one big downward deflection, which of course has to be a QS pattern.
It's time for another little exercise. Now it's your turn to identify the different components of the ECG. Try to identify the QRS complexes and the T waves first, and then the P waves. So pause the video and try for yourself, then come back and see how you did.
Welcome back.
Okay, so I hope you did the exercise. Let's see how you did. This first part of the curve, very steep and pointy, must be a QRS complex. Then after each QRS complex, there has to be a T wave, so this has to be the T wave. Then this is another steep part, QRS complex. This must be a T wave, rather flat. QRS complex, T wave, QRS complex, T wave, QRS complex, and another T wave. So what we're left with are a couple of unidentified dotted lines and ECG curves. And those curves must be the P waves because the QRS complexes and the T waves we've already identified. So this must be a P wave. This must be a P wave. Another unidentified line must be a P wave. And then another P wave here and another P wave here. What's striking here, though, is that the P2P interval here seems fairly long, and those three P2P intervals seem much shorter, right? So these three seem to be constant, and then there seems to be a big pause. And one important thing to note is that the P's are only very, very rarely skipped. So we assume that the P wave must be hidden somewhere in this interval. But where? Well, the way to solve this mystery is to take the P2P interval, the regular P2P interval, which would be this. These are three regular P2P intervals. And then take this P2P interval and put it right here at the first part of this pause. So we put it here, and so we see that this is the area where we would expect the P, right? So this is where the P is supposed to be. And I can tell you, the P is actually hidden within the QRS complex. That's why those two are happening at the same time. And then comes another regular P2P interval. So the mystery for this long pause is solved. But then we have another little mystery. Here, in the period that comes before this P wave, there's no P happening here. So let's take the P2P interval, and we can see that this is the area where we would expect the missing P. And if you look closely down here, you can see that we have a little bit of notching here. That's probably because the P wave is hidden within it.
Now try for yourself. Start the exercises and see how you're doing, and I'll see you in the next session.
Okay, what did you guys think? You know, not bad. You know, it's just a video, but it's a pretty good start. If you want to get into ECG reading, I would suggest this Med series. It's actually pretty good. It's called Med Mastery. You can go to medmastery.com and check that out. So I may throw some videos at you for homework, and I think that'll be a good exercise for you guys, especially to get into some of the reading aspects of this. Okay, so this is what we're going to talk about for the rest of the lecture. We're going to talk about arrhythmias, atrioventricular block 1 through 3, atrial fibrillation, cardiac valve disorders, acute coronary syndromes, infective endocarditis, abdominal aortic aneurysms, and deep venous thrombosis and varicose veins. Let's talk about ECG. We did that. Okay, let's get into arrhythmias. Here we go. So the normal heartbeat is caused by regular and coordinated generation of electrical impulses that trigger organized myocardial contractions. So as we know, the normal rhythm is 60 to 100 beats per minute, but it may be slower in athletes, and during our sleep pattern, we tend to get below 60 often. Increase during inspiration and decrease during expiration are normal but may lessen with age. Arrhythmias are abnormalities in generation or conduction of these electrical impulses. So here's kind of a cross-section of the heart looking inside, the atrial aspect and the ventricles on both sides, and some where the electricity happens. You have your sinoatrial node. Up here, you've got your right bundle branch blockage, or in case there's a blockage, this would cause some problems. You have your atrioventricular node, your AVN. You have your bundle of His, and you have your left anterior fascicle and your Purkinje fibers. So let's go ahead and discuss what arrhythmias are. So signs and symptoms of arrhythmias. You may be asymptomatic, but you may have palpitations as well. You're going to have dyspnea, chest discomfort, pre-syncope, syncope, and they diagnose this with an ECG. Treatment. We've got to do the correction of cause. Can we make a change in these folks? Yeah, we can. It's got to be a serious lifestyle change. And, eventually we can get them off these antiarrhythmic drugs. But if the damage has been done, sometimes it's just too late, right? So if it gets too bad, they put them on the drugs and they give them the pacemaker, and then they can do cardioversion. They can do ablation of ectopic site of automaticity, and then they also have an implantable cardioverter defibrillator. So that's kind of a trip, right? They can actually defibrillate a fibrillating heart. It's already it's implanted inside of you. So that's really a trip. Anybody have any patients that come and see them with a defibrillator? So if you do, be careful. There's contraindications for, pacemakers and things like that. Really look into it. Talk with the other physicians before you start. Especially, I want you guys to look at the CNT manual. Again, I keep bringing that up, but for the assignment, maybe I'll include some type of CNT research where you have to find out, look up defibrillator and look up pacemaker and see what it says in the clean needle technique manual. Okay, here we go with the atrioventricular block. It's either a partial or complete interruption of impulse transmission from atria to the ventricles. So, it's from the right side of the heart over to the left side, right? So there's most commonly caused by idiopathic fibrosis or sclerosis of the conduction system. So with your first degree block, the conduction is actually slowed without skip beats, but as you progress, it gets worse. And it may be physiologic in well-trained athletes. I told you a story about my friend that, he probably had something like that going on with this. So it does not require any treatment, and it's rarely symptomatic. And this is what it looks like on the ECG. So if you guys can take a look at that, you can pause it, try to identify some of these waves based off of the rules that you watched. So the PR interval equals 0.32 seconds. So you're going to have to watch a couple more videos to understand how they measure these, but we'll get on that. But just understand that this is what an atrioventricular block first degree looks like. The atrioventricular block second degree block is actually a Mobitz type 1 or a Mobitz type 2. The PR interval progressively lengthens with each beat until the atrial impulse is not conducted and QRS complex is dropped. The conduction resumes with the next beat and the sequence is actually repeated. So the Mobitz types 2, the PR interval remains constant and beats are intermittently not conducted and the QRS complex is dropped. So a high-grade block, every second or more, P wave is blocked and QRS is dropped. This is what a Mobitz type 1 looks like, and you'll get into these when I send you the videos. You'll be able to tell how to measure these squares both vertically and horizontally. This is a type 2, Mobitz type 2 block. And this is a high grade atrioventricular block, 2nd degree high grade. So 3rd degree block, there's actually no electrical communication between the atria and the ventricles, and no relationship between the P waves and QRS complex. So the function maintained by ventricular pacemaker or escape rhythm is 40 beats per minute or less, and most patients will require permanent pacemaker. So this is serious, right? That 3rd degree block. So this is what it looks like. And you're welcome to come back and pause these video, take a look at some of these squares once you get that class, and see if you can identify. Atrial fibrillation, it's a rapid, irregular atrial rhythm. And even in Chinese medicine we have irregular, right? And some of our diagnosis. So, and it's interesting to me that we have all these pulses, and you know, we should be taking this seriously. I think this would help us with our Chinese diagnosis as well. So the atria do not fully contract, and the AV conduction system has many electrical stimuli causing irregular ventricular rates. So how does it happen? So it's most commonly due to high blood pressure, cardiomyopathy, mitral or tricuspid valve disorders. So either side, you might have a disorder on the left or right side. Okay, so for homework, know that heart. Tell me which side it's on. The mitral is on the left or right? Is the tricuspid on the left or right? Also hyperthyroidism, because with hyperthyroidism, what? We have an increased heart rate. Binge alcohol drinking, I think we talked about that earlier, and that it can cause an increased heart rate. So be aware of that. So how do we know what's going on? What are the signs and symptoms? Well, sometimes we don't. Often it's asymptomatic. He may or may not have palpitations, or she. Vague chest discomfort, pulse irregular, and then there's going to be a pulse deficit. So how many times has a patient come to see you and you're feeling their pulse and you're like, man, this person, I can hardly feel it? Well, you got to look out for that. I take this person's blood pressure. I would see if there's a red flag. Not necessarily if you can't feel it, but you know, if he keeps coming to you and he's got, you know, one day you can feel it, the other day you can't, you know, there's probably something going on in there. So apical ventricular rate is faster than the rate palpated at the wrist, and we palpate at the wrist, right? Maybe you should actually check it in a few places. You know, you could actually, you know, check for the carotid pulse. You know, look up here and see if, you know, see what's going on, because the stroke volume is not always sufficient, again, to produce the peripheral pressure wave. So that's a quick way. You know, the blood pressure is actually, if you can get you know, you can get a pulse down at the peripheral, you know, the blood pressure is at a certain, you know, certain area, right? So that's one quick way of finding out if their pressure is at least, you know, good enough to pump it down, you know, to the periphery. So how do we diagnose atrial fibrillation? So, and understand that fibrillation is just that heart is just kind of fibrillating, man. It's just shaking around, not knowing. And it's how do we diagnose that thing? So it's through an ECG. You'll have an absence of P waves, and you know what a P wave looks like now. Out of the rules, another homework assignment is find out what concept, you know, what does a P wave actually look like? QRS complexes are irregular in timing. Echocardiography to assess for any structural defects, right? Because they'd actually go inside and check it out, and see it on a camera. And, you know, they'll look for valve disorders. You can do a thyroid function test. And for treatment, they're going to try to use drugs. There's cardioversion, ablation of AV node, and insertion of a permanent pacemaker. And I'll send you guys a good vocabulary for all this stuff. And prevention of thromboembolism. So we're always concerned with throwing clots, right? So they may give this patient warfarin, oral anticoagulants. For other cardiac valve disorders, we can talk about aortic regurgitation, which is incompetency of aortic valve causing backflow from the aorta into the left ventricle, back into the left ventricle, right, during diastole. So that's not good. So how does that happen? Well, we usually find out later that the person had or has infective endocarditis, or there's a dissection of the ascending aorta. Could be through trauma or wear and tear. Rheumatic fever causes some other problems, not only with the heart but other organs. But there's actually a lot of literature on rheumatic fever and how it causes heart issues, heart valve issues. And signs and symptoms, typically it's going to be asymptomatic for years. They're not going to even know. Later on, they'll have exertional dyspnea, orthopnea. What's orthopnea? Look that up. Orthopnea is actually difficulty breathing lying down, right? Palpitations. They're going to have a normal S1. S1 is that first heart sound. Non-split with a loud S2, second heart sound. Blowing, high-pitched diastolic murmur. We know what murmurs are. Look into that. I gave you a vocabulary. Look what murmurs. We covered that first week. And it's heard best with diaphragm, with patient leaning forward, with the breath held at expiration. So these are one of the tests that they could use, similar to what we do when we do musculoskeletal testing. We these people, these cardiologists and these physicians, they'll actually, they'll be using these lean forward, breath held at expiration. They'll be given these directions to the patient. It's diagnosed via the echo, and we treat it with aortic valve replacement or repair. So aortic stenosis is just narrowing, right, of that aortic valve. So due to obstructing blood flow from the left ventricle to the ascending aorta during systole. So it's just a narrowing of the aortic valve, right? And the signs and symptoms, exertional syncope. So I talked about exertional versus non-exertional syncope. You know about that. So if this person is getting, fainting during exercise, what about if they're not exercising? So it means it's more serious, right? Angina. It's going to be feeling some pain. Difficulty breathing. They're going to have a normal S1, single, non-split S2. Crescendo, decrescendo, ejection murmur heard best with the diaphragm at the right upper sternal border with patient leaning forward. It decreases with the Valsalva. Valsalva, what's a Valsalva? I bet you asked. So Valsalva is actually, you bear down, you close your nostrils and you bear down so the pressure comes up and you can release the pressure between your inner and outer ear. A lot of scuba divers, this is what we do to go down to different atmospheres, and it allows us to equalize the pressure so we don't bust an eardrum. Diagnosis is through echocardiography. So the echo, the magic echo, it comes up a lot on these because whenever you see valve disorders, you're going to see echo in the diagnosis because they're actually looking at the valves. They can see the valves. The ECG will only tell you so much, but some people that are really good at reading those can actually, they could actually predict a lot of the stuff that's going on. And the treatment is the aortic valve replacement. Mitral valve prolapse, what side's that on? So the billowing of mitral valve into the left atrium during systole. So I just told you which side it was on. Usually benign, and complications include mitral regurgitation, endocarditis, chordal rupture. Chordal, so a lot of that chordal stuff is like that connective tissue to hold everything together in there. Sometimes this can get ruptured in trauma and sometimes from wear and tear. Signs and symptoms, it's most often asymptomatic. Mid-systolic click heard best with the diaphragm over the left apex. The apex is the top, okay? Or the bottom, as you were. Yeah. So diagnosis, again, is with the echo. Yeah, and this does not usually require any treatment. However, if it gets pretty bad, it can get bad, right? So always be on the lookout. Our next disorder, a valve disorder, is mitral regurgitation, which is incompetency of mitral valve causing flow from the left ventricle into the left atrium during systole. And it's not too cool, right? So most often caused by mitral valve prolapse. This eventually leads to heart failure as the left ventricle compensation fails, right? So they're going to have insidious development of dyspnea, fatigue, orthopnea, palpitations, holosystolic murmur heard, best at the apex with the patient in the left lateral decubitus position. So we used to place patients in the left lateral decubitus, yeah, for diving emergencies, right? So wanted their left side down, and it decreases with Valsalva. So the diagnosis with it's going to be again with the echo because it's a valve. Just understand that. That'll come it'll become handy when during test time you may see a test question about valve disorders and echo being together. Treatment with mitral valve repair or replacement. So here's your lateral decubitus position. You know, I don't know if we're going to be doing all that, strapping them down and all that stuff. Looks like they're going to do some type of procedure to this person. But yeah, so that's just the position, right? They may, but you know, I've seen, you know, at different clinics in Berkeley, you know, they use these type of tables for acupuncture, and some of the community clinics, and they put a bunch of pillows and stuff like that for folks. Just makes them feel better, especially with the you know, the flank that's elevated and the, you know, the pillow between the legs. But we didn't strap them down or anything like that. But yeah, it's left lateral. Next one is mitral stenosis. Stenosis, you know what that is. It's a narrowing of the mitral orifice that impedes blood flow from the left atrium to the left ventricle. Most often caused by rheumatic fever. Here we go again, rheumatic fever. Seems to be the common denominator in a lot of these things, right? Complications, pulmonary hypertension, atrial fibrillation, thromboembolism. Signs and symptoms, those of heart failure. They're going to have exertional dyspnea, orthopnea, fatigue. Loud S1 is heard best at the apex. Apex is where? Look that up. It's at the bottom. Sounds like the top. It's not. The bottom. Early diagnostic, early diastolic, opening snap as leaflets billow into the left ventricle, followed by a low-pitched D crescendo rumbling, diastolic murmur heard in the left lateral decubitus position. So it increases after Valsalva or squatting, and the diagnosis is again by echo. Early treatment with diuretics, anticoagulants later, and you have what's called a commissurotomy or valve replacement in the event it gets so bad. So Here we get into the acute coronary syndromes of myocardial infarction. And this usually occurs when acute thrombus forms in a atherosclerotic coronary artery. So that's the how blood moves throughout the actual heart tissue through the myocardium and everything to power up the heart. So you're going to have those arteries are going to be occluded, right? And blood flow to the parts of the myocardium is disrupted, resulting in tissue necrosis. Bad deal. Most commonly affects the left ventricle, reducing cardiac output, and the ischemic and necrotic cells are not capable of normal electrical activity. So that's a key point too. Not capable of normal electrical activity, resulting in ECG changes. Signs and symptoms of an MI depends on the extent and location. 2/3 of the patients experience prodromal symptoms, days to weeks, to include unstable angina, shortness of breath, fatigue, and some of them have a deep substernal visceral pain described as aching or pressure. Some will tell you it feels like there's an elephant sitting on my chest. They have radiating pain to the back of the jaw, either arms, shoulders, or all of the above. Some feel like impending doom, like I am going to die today. So yeah, listen to them, because if you don't get them to a hospital, they probably will. Dyspnea, they can become diaphoretic, nausea, vomiting, and nothing is relieved by their nitroglycerin pills they normally take for angina. You can tell that this is a serious situation. Some are silent, may go asymptomatic or causing vague symptoms. And also it's more common in, guess what, diabetics. There you go. Man, diabetes is killer, right? That sneaks up on you. Pre-diabetes, all fun and games now, man. But diabetics, you got diabetes, cancer, heart disease. You know, these three, man, they seem to work hand in hand with each other. You know, those systems talk to each other. And women are likely to present with atypical chest discomfort. Continuing on with the signs and symptoms, it's important to mention that these people can have pale, cool, clammy skin. Their peripheral or central cyanosis. They're going to have a thready pulse. You know, we're experts at taking pulse. We know what thready feels like, right? But this is going to be weak and thready. It's maybe going to be a little bit weird. Heart sounds are distant and muffled sounding, and the S4 sound is almost always present. Well, if it's almost always present, you know there's a problem, because S4 sounds normally don't occur. So it's an extra sound that's normally not present. So risk factors with MI, these people will have recurrent angina at rest or low-level activity. So that's a key. I would put a star next to that, because you're going to have to know a lot of disorders they try to say, okay, is this person serious or not? Is he getting this at rest, or is he getting this, you know, with some type of activity? So it's important to note two different, stable versus unstable angina, those kind of things. And there's a couple other disorders that I've mentioned in the past that you'll see on test questions. Heart failure, this happened in the past. Does he have mitral regurgitation? Stress test result of symptom production. ECG abnormalities. ECG's coming up again. We haven't mentioned that in a while. It's all been the echo. Ventricular arrhythmias, right? So also there's going to be some hemodynamic instability with these folks. Diabetes mellitus and prior CABG and PCI. So this is what a stent looks like in the coronary artery, and has a guide wire and a catheter. The guide wire slips through that that catheter, and some have like this mesh that allows it to to burrow through and keep it keep it patent. And how do we diagnose an MI? So you're going to have an ECG every 8 hours for 1 day, then daily to track changes. Cardiac markers are serum markers of myocardial cell injury that appear at different times after the injury and decrease at different rates. These cardiac markers, troponin, at presentation to the hospital, you're going to see creatine kinase, MB, myoglobin, and then coronary angiography after abnormal ECG. So that's what it looks like. All right, looks like something happened there in that valve. Looks like it has some type of separation right there, right? So these are kind of some of the abnormalities they're looking for. Here's some of the cardiac markers from hours from onset of infarction to the upper limit of normal. What's normal for myoglobin at these different hours and onsets. Acute coronary syndromes. How do we treat this, right? How do we treat the MI? Of course, we're going to put oxygen on them right away. We're going to get them on some anticoagulants, antiplatelet drugs, nitroglycerin for the pain, initial bed rest for 24 hours, low salt, low fat diet. Treat contributing disorders, treat the anemia, treat the heart failure, treat any other secondary or primary, right? What's actually causing this? A lifestyle? Is it diet? Is it, predisposed conditions they can do nothing about, but could make some modifiable changes in their lives? Complications. So complications include electrical dysfunction. There may be conduction disturbance or arrhythmias, mechanical dysfunction, heart failure, myocardial rupture, papillary muscle dysfunction, thrombosis, and pericarditis. Infective endocarditis is an infection of the endocardium, usually bacterial or fungal. How does it happen? Well, it usually involves defective heart valves that allow the bacteria or fungus to adhere to endocardial surface. You may have microorganisms in the bloodstream, parasites even, right? And cutaneous abscess. This is an important one. Infected gums. Dentists are all over you these days about avoiding heart issues, avoiding infective endocarditis by getting your teeth cleaned, keeping your gums healthy. UTI. Interesting, right? Venous catheter could be caused by a venous catheter. And drug injection sites. Signs and symptoms: low-grade fever, night sweats, fatigability, malaise, weight loss. These folks may have a regurgitant murmur. They're going to be tachycardic. They may have hemorrhagic retinal lesions, petechia, painful erythematous subcutaneous nodules on the tips of their digits, and transient ischemic attack, stroke, toxic encephalopathy. How do we diagnose this? Through blood cultures. Echoes coming back. Echocardiography. Blood culture, 3 within 24 hours from separate. Fresh venipuncture sites. Identification. They're done at 3 different venipuncture sites, right? For that blood culture. Identification of organism and antimicrobial sensitivity. Treatment with IV antibiotics. Valve repair or replacement. Prophylaxis before procedures. Make sure to get good dental care, right? Abdominal aortic aneurysm. This is an increase in diameter to greater than 3 centimeters of abdominal aorta. It typically begins below the renal arteries and most commonly caused by weakening of the arterial wall by atherosclerosis. Many risk factors involved. Smoking is going to come up again. high blood pressure, increasing age, family history, male sex, and black race. Signs and symptoms. It says here most are asymptomatic, but maybe steady, deep, boring, visceral pain in the lumbosacral region. Yeah. So someone could be complaining of, this visceral pain down below, and pulsatile abdominal mass can definitely be felt. Diagnosis through clinical presentation. Ultrasound or CT and CT angiography shows size and extent of the aortic aneurysm. So treatment, monitoring if greater than 5 centimeters, surgical repair if less than 5 centimeters by replacing if greater than 5 centimeters by replacing the portion affected by the aneurysm, right, with a synthetic graft, right? So if it's less than 5 centimeters, it's going to be monitored. Greater than 5, you're going to replace it. So DVT, these are clotting of blood in deep vein of an extremity, usually the calf or thigh. So risk factors, increasing age, cancer, cigarette smoking is going to come up and up again. Estrogen receptor modulators, breast, ovarian cancer treatments, oral contraceptives, heart failure, hypercoagulability disorder, immobilization, indwelling venous catheter, limb trauma. Okay, that's always have to be cautious with someone, busts a leg or something. Hey, there's clots you can throw something from there. Myeloproliferative disease, nephrotic syndrome, obesity, pregnancy, postpartum, and prior venous thromboembolism. And how about surgery within the past 3 months, right? And sickle cell anemia. So, okay, here's the left leg. I guess they're just showing you the different vasculature. You have your anterior tibial, your posterior tibial, and your peroneal. And mainly it happens in the calf a lot, right? That's where the DVTs normally happen. You hear stories of folks flying, overseas on these long flights and getting stuck. They probably have poor circulation anyway, and they get clotted up and then they throw a clot. So deep venous thrombosis results from impaired venous return, right? And endothelial injury or hypercoagulability usually begins in the venous valve cusps. Complications, very chronic venous insufficiency. They can have stasis ulcers or a pulmonary embolism, at which point that's a serious thing where it could actually cause a complete cessation and necrosis in the pulmonary region and a lack of circulation there. It could clot it up that bad. So it's pretty serious. Factors in presentation that increase the probability of DVT. Here we go. Tenderness along vein distribution in calf or thigh. How about unilateral swelling of the entire leg? Calf swelling greater than 3 centimeters. Difference between calves. Pitting edema in affected leg. Dilated superficial veins. Cancer. Immobilization, right? And history of surgery within the past 4 weeks, especially if immobile, post-op. How do we diagnose it? Ultrasound, D-dimer test. It's a byproduct of fibrinolysis, determination of cause if not from immobilization. How do we treat it? Injectable anticoagulation therapy initially, oral anticoagulant for 3 to 6 months if risk factors were transient and lifelong, if non-modifiable. Prognosis, 3% risk of fatal pulmonary embolism without treatment. So prevention, we have to increase our mobility, keep these people moving. Risk assessment prior to invasive procedures and intermittent pneumatic compression. Varicose veins. So this is our last portion. So they're dilated superficial veins in the lower extremities, and it may result from primary venous valvular insufficiency with reflux, symptoms and signs. It's initially tense and palpable, but not visible, and it's progressive enlargement, protrusion, most visible on standing. Diagnosis by clinical evaluation. Treatment: compression stockings. They sell them right at any of these Walgreens stores or CVS. You'll see those a lot out there. Usually next to the canes, they'll have like these little compression stockings. Sclerotherapy or surgery, but new porosities will develop. Okay, here's a cafe rider, on his bike shoes on. You can see it's pretty obvious right there, his left calf. Right there, there's some varicose veins right in through there. All right, so this is what we talked about today. We talked about arrhythmias. We talked about the AV block 1 through 3, and atrial fibrillation. We talked about that. Cardiac valve disorders are going to go hand in hand. Any type of valve disorder, we're going to diagnose that with what? Echo, right? So we hit up on the ECG. I gave you 5 good concepts to understand what these things look like, little rules to follow by, and a baseline to start, if you want to, go into more advanced training on the ECG. I think it's a good idea. We talked about acute coronary syndromes. We talked about infective endocarditis and abdominal aortic aneurysm. We talked about deep venous thrombosis and varicose veins. So with that in mind, I'd like to say goodnight, and I'll get this posted soon, and you'll see it. It'll be there probably. You'll be probably watching this either Tuesday morning or staying up late Monday night and watching this. I'll associate this with a 10 question quiz that'll be due next week on Tuesday, and we'll meet tomorrow briefly and discuss the tests or any exam questions, and we'll go over any questions you have, maybe go over some of the vocabulary I covered, and issue guys a good vocabulary sheet for cardio. I'd encourage you again to get more familiar with the ECG. It's a good tool, and if you ever get a chance to work in a hospital setting in cardio, it's a good place to work. You learn a lot, and people are very resilient. They're super resilient, and you'll be surprised what they can survive. But you guys have a great week in Oakland or wherever you guys are residing. Stay safe, and I hope to see you guys tomorrow for a check-in. All right, peace out here. Have a good one.